You so much, Stephanie. So I'm just going to get started and then pass it over to Lexy. We wanted to, as we just share the learning objectives, we wanted to invite people that were in the room if you feel like sharing a bit about what brought you to the session today, whether that's, where you work or what your interest is in the topic. What we're hoping to do today is to talk a little bit about shifting the gaze up to the dominant kind of perspectives on family caregiving and palliative care by mostly focusing on how caregiving can look a little different in context of homelessness. We hope to describe the need for new models and of engagement and support for caregivers, and then also hope to leave people with something to take away from our session today, which is something we'll do at the very end with a little round. So, as Stephanie mentioned, I've worked with the Palliative Approaches to Care in Aging and Community Health Research Program at the University of Victoria over the last decade. And then Lexi just shared with me that she started in 2020. So we were saying how much time is really just flying by. Um, when I first came on to work with Kelly Stajahar over a decade ago, she was just starting a study that was looking at the end of life experiences of people that were facing homelessness and other inequities. And we used an ethnographic approach to the research, which really meant that we integrated ourselves into lives of people with consent, obviously, to really understand the kinds of barriers that they were facing to care. But most importantly, maybe equally important, uh, seeing really like the facilitators to care. So who was it that was showing up to be the supportive circle of care around people at the end of life? How did they help? What kinds of challenges they faced as the people that were the caregivers? And these early studies really kind of shaped how we moved through the program of research after the first few years to look at how do we better improve access to like support and services for people living with serious illness and care at the end of life. But then, most importantly, how do we support the whole community of people, not just people that are kind of living with serious illness, but the people that are providing care around them, the service providers, the workers that might be not seen as caregivers, which we're going to talk a little bit about in this presentation, the street family, the friends, the neighbors, and really like taking in a kind of compassionate communities approach to the work that we were doing. Um, and so, yeah, that's kind of what we're going to draw on today. And so we're not really going to get into one particular project, but both Lexi and I, for over the years, have worked on multiple projects that have really um, s- focused on, yeah, like this circle of support. So we kind of wanted to share with you about insights around caregiving. So why is it important to critically examine our assumptions about caregiving, family caregiving at the end of life in context of homelessness? So we know that about 75 to 90% of home-based care is provided by family caregivers. And palliative care, of course, is person and family-centered care. But palliative care and also palliative care has been, I should say first, one of the places that has really recognized the important roles of caregiving. So when we look at like other areas of the health system, I feel like palliative care is very much like, okay, where's the family at? Where are the friends at? How are we engaging them in the care? But palliative care is also in its so-called equity turn, which is a real recognition that mainstream kind of palliative and hospice services have largely served a very middle class, kind of well-resourced, historically pretty white population that is very much, yeah, like high educational, a lot of cancer patients as opposed to other health conditions. Um, and so there's a real recognition that, policies, practices that exist in palliative and hospice care aren't neutral. They've kind of come from more of a Western understanding, not historically, but definitely in the modern kind of palliative care movement. And a recognition that hospice and palliative care really needs to kind of work to improve access to its services for people that, might fall outside the tick boxes of who palliative care has served in the past. We know from like 2S LGBTQ inclusivity and justice, activists, people in the community have written about conceptualizations of family caregiving outside of biologically or legally connected family. And so we've learned a lot from those communities that family can look different. In the context of homelessness, what we've seen in our studies, and we're going to talk a little bit more about today, is that there tends to be more family estrangement. So tends to be more estrangement from biolegal family or biologically or legally connected family, and more support offered by workers that are working in housing and social support agencies, maybe friends and street family. But obviously, biolegal family still can be involved. And we found also too that the caregivers that are in these contexts are often also facing some of similar social disadvantages of the people that they're providing support for. Things like poverty, homelessness, racism, discrimination. Those are also impacting the caregivers. But really importantly, what we always like to try and say in these presentations is that, we are focused on homelessness, but there's these broader kind of demographic shifts around like families living further apart, people choosing not to have children, that are really kind of starting to disrupt the idea that care at the end of life is provided within, family, nuclear, cohabitated households. And there's trends towards people looking externally for care and support at the end of life. So with that, I'm going to just pass her over to Lexy to get us started, just to talk about some of the lessons that we've learned around caregiving in context of homelessness. And then we're going to have a bit of discussion, and then I'm going to come back and talk a bit about some of the recommendations that have come out of our research.
Thanks, Ash. Okay, yeah, so we're going to move into some of the higher level findings that we've been seeing in our work. And as Ashley said, one of the things we've seen in our research is that some of the assumptions we make about caregiving don't necessarily hold in context of homelessness and other inequities. And really, this idea that family will naturally be there to provide care at the end of life has become a really important tension for us to explore. And so when we started looking more closely at people's actual care networks, they were often much more intricate than the traditional idea of a family caregiver. And we found that care was happening through a much broader network of relationships, and that those relationships could also change over time. So one of the things we really wanted to think about is what happens when the people providing care don't like neatly fit into the category of family. And so, one of the things that Ashley mentioned too is that we found a high level and high degree of estrangement from biological and legally connected family. So, again, while there often is this assumption that family will be a part of someone's care network, we found that lots of people are disconnected from their biological family. And are often accessing care from a wide range of people. And this really challenges, again, the idea of family and what we mean when we use the word family, and whether our systems are actually recognizing the people who are providing the care. And so what we've really seen is a constellation of people providing this support. And these people often show up as friends, neighbors, partners, as well as workers in health and social services, with people often taking on very different roles. Um, and I think it's really important to point out that these relationships aren't necessarily fixed. Someone might be providing a lot of support at one point and then becomes less involved when another person steps in. So I would say rather than thinking about caregiving as one person providing care to another person, we started to see it as something that was distributed across a network of people and supports essentially. And these relationships they were almost never one-directional caregiving relationships. Um, People were often caring for each other while also experiencing many of the same health and social challenges themselves. And the other thing that we found is that most people don't actually identify as caregivers. So the idea of the caregiver and the language around caregiving didn't always really fit what we often see in the literature. And we found that it looked a lot more like like a community model of care that was like rooted in mutual caregiving relationships. And so this next slide is just an example that really captures that idea of mutual care. And I'm just going to read this one out loud. So Ronald lived with multiple comorbidities and was labeled failure to thrive by his palliative care team, while David lived with mental health and substance use issues resulting in ongoing falls and hospitalizations. An outreach worker told us that they were best friends and that they met each other in their subsidized housing facility. Beginning as drinking buddies, their relationship grew from there, and during this study, they supported one another by visiting each other in hospital, providing each other emotional support, and sharing the costs of groceries and supplies. During an observation, David told us, I look out for him and he looks out for me. And I think I just really love that end quote from David because it really captures the reciprocity and of the relationship and really highlights how they were both a part of each other's support system rather than a one-sided caregiving relationship. And so the next important finding is that we really found that the role of place had huge impacts for caregiving relationships. So we found that where someone lives and the policies and practices within that space can really shape who is able to be a part of that person's care network. And so things like housing policies, spatial and geographical barriers, and stigma within spaces can make it more difficult for certain relationships to continue. Um, and so this could really mean someone who is really important to someone's care was unable to visit then, unable to access a space where care was happening, or wasn't recognized as someone who should be involved in their care. And we found this a lot more in institutionalized settings, but also in shelter settings where there are no guest policies, which can really isolate people from their support systems. And so, yeah, this really leads into the invisibility of those relationships. So we found that throughout a lot of our studies that these relationships can be very difficult for the systems to recognize. And so people might not have the legal, financial, or technological resources to formally document the relationship. And there can also be challenges with literacy and navigating complicated systems in general. Um, and so we often see that someone might be providing a huge amount of emotional or practical support, but there's no formal recognition within the healthcare system. And so they may not be documented as a decision maker or even a part of that person's network of care. And this becomes really important at the end of life when systems need to know who can make these decisions, like who should be contacted, and who understands that person's wishes. And a lot of the time, the people that know that person the best may not be the people who appear in the chart or like fit within existing legal categories. And so I think this next quote really captures some of the assumptions and judgments that surround these kinds of caregiving relationships. So this housing manager is recognizing that people are looking after each other, but at the same time, the language of the blind leading the blind really frames this care as somehow inadequate or problematic. And so part of what we're trying to highlight here is just the importance of recognizing these relationships as legitimate forms of care rather than judging them um, based on whether they fit in more conventional ideas of what a caregiver or what care should look like. And so we also saw that workers can occupy some of these pretty complicated and complex positions. So they may be paid to provide care, but over time they can develop very close family-like relationships with the people that they support. And so when this happens, the distinctions between worker and friend, or even like professional and personal, can become a lot less clear. And so a worker might be providing emotional support or doing things that go well beyond what traditionally would be considered a part of their job or out of scope of their practice, which can create really difficult ethical and workplace boundaries. And there can also be consequences for the worker if they're perceived as crossing professional boundaries. So again, we're just seeing relationships that really don't fit neatly into these categories that our systems are built around. And then, so we also found that it's really important not to assume that estrangement means family will never be involved again. So end of life can actually be a time when reconnecting with family becomes extremely important. And sometimes family members may re-enter quite suddenly and actually take on like a larger caregiving role. And in some cases, we kind of saw this unspoken kind of stepping down from friends or chosen family to make room for those biological relationships. Um, and at the same time, this can also create some really complicated dynamics, particularly when friends or chosen family have been providing care for a long period of time, especially because they may know the person extremely well, but suddenly feel like less involved because they don't have the same legal or biological status. But yeah, like all to say, we do see biological family members re-enter these relationships at end of life and do often assume a caregiving role in some of these cases. And finally, what we saw was these experiences have implications beyond the person who is dying, and people's support networks can experience significant grief. And for people who are already experiencing social and structural inequities, that grief can be complicated by the circumstances surrounding the death and by whether or not their relationship was recognized or supported. And so we've really seen death and dying as having this ripple effect beyond the person who has died, and how that compacting grief impacts like entire communities and networks of support. And yeah, so those are kind of our high level findings from the studies that we've done over the last couple of years. And I just want to reiterate that a big part of our work is really looking at strength-based approaches and not seeing things as deficits and trying to look at the strengths of our community and build those pieces up and see how we can support those. So, like Ashley said, the next part of our presentation is really going to focus on what we can do about some of those things and work through some of those barriers. But before that, I just wanted to open up the floor and ask if anyone has seen similar barriers in their work, if any of this information resonates with you, or any of these challenges are showing up in your workplaces. Put it in the chat. People can raise their hand.
Yeah, I'm just taking the screen off so I can see people and see any comments in the chat. And yeah, feel free to just jump off mute. Yeah, go ahead, Sarah.
I definitely see like challenges with when it comes to information sharing, sometimes across teams, and just sometimes like despite the person like signing releases of information and things, there's usually a lot of red tape in what different teams are able to share, especially if they're not all a part of like the health authority and maybe their support team is, part of like a nonprofit that's like outside of the scope of the health authority or things like that. It can be a little bit tough. I also see often as well, like their self-identified support circle. So like there's other supports like in their street community, what you guys were talking about, not realizing and like those as part of like a real circle of care, and then also like not relying on those relationships in a meaningful way, then I think creates other barriers. So I'm really glad that you guys are reframing a lot of this because it's giving I think it'll give a lot of language to how we can begin to kind of promote that systems change. Thanks for the work you're doing.
That's awesome. Thank you so much, Sarah. We have a couple of comments in the chat. One is when the people get admitted to hospice, sometimes their buddies do not feel comfortable visiting them in the healthcare facility and feel marginalized in that environment. Really good point. Megan, I echo the challenges in sharing information, but also with people who have expressed wishes to have their friends make their decision, but don't have formal documentation in place. Yeah, for sure. Definitely see that. Lola, I can relate to the tension and dynamics when family suddenly shows up at the end of life, when all the while their non-bio caregivers have been supporting all along. It can be really tricky. Yeah, for sure. And it's totally something that we've seen because there's such a lack of like family complexity support we find. And then so it's like layers upon layers of complexity. And I think it is attending to what the person wants, but we know at the end of life, like as people start to, lose sometimes their capacity, and then other people take things on. And then we've got kind of like who is seen as the caregiver and who's and who is documented as the caregiver and who wants to just visit, and recognizing that there could be multiple roles and multiple relationships. And that, as Lexi said, those relationships aren't always fixed. It could be someone that's in an on again, off again relationship. And maybe it's an on time, not an off time. So it's hard to figure out in a way in a system that often conceptualizes these relationships as really fixed and like this is the person you want to make decisions for you that doesn't change. Whereas we see a lot of change and fluctuation in relationships too, which I think is really like human, like I think we all, if we were really honest about many of our family dynamics, there's lots of fluctuation and changes, and things are not fixed for many people. It's not just a kind of homelessness context. Joshua says, I see the challenges in grief support. And then Nell says, caregivers of PEH are also PWD. When institutions, people experiencing homelessness are also people with disabilities. When institutions are enforcing strict policies, no visitors, physical structure does not accommodate wheelchair, service dogs not allowed because no dogs allowed. Yep, absolutely. A lot of the settings where people are living, experiencing serious illness, decline, and dying. And then that is, as you say, not even like counting people that already have disabilities. There's a lot of expectation for independence. Like, okay, you need to be able to get down to get your own food, or you can't have a caregiver or a partner or a pet live with you, or come and access your room. So, like that kind of thing. It's really not, the settings aren't built for interdependence. They're very built for independence. Lexi, do you want to say anything more about that just from your research?
I was just going to say it's interesting now that you have brought up the physical structure that doesn't accommodate for wheelchairs because it's huge. Like, we really do see all of these issues with place and space in so many of these settings that, yeah, they're honestly just not built to accommodate diverse needs. And it's really frustrating because then there's all these policies they put in place about whether you're independent or not and whether you can live, yeah, in certain places. And it's been really interesting to just to see who qualifies for home care and who doesn't qualify for home care based on certain things and just the needs of the population. So yeah, we definitely look a lot at place and space and just the things that people would need in order to be cared for in the community. So yeah, it's a really good point.
Thank you for everyone's really, really important insights that you shared in the chat and in person. And we'll have some more time for discussion because this next part isn't going to take us till the end. So, but I'm going to share my screen again. If I can find the button. Oh, there we are. Okay. So yeah, so we wanted to go into a few high level discussions about kind of what we can do about it. Um, on a high level, just the need for equity-oriented approaches to palliative care. And this is just, we always say this in a lot of the aspects of our work, but really around like really like hard reflections, like equity oriented care isn't kind of about looking at those people over there and wondering why they're not coming to our services, but rather a shifting a gaze towards the services ourselves and the potential barriers that our organizations and institutions are putting up so that people don't feel, as was mentioned in the chat, comfortable to access services or can't get to services, or like what are the structural considerations? How is the environment laid out? What are the rules that we put on people? What culture are we putting forward in our in the way that we operate? What does that say about who's allowed or not allowed to be there? So I think just again, very high level, just this opportunity to really look at ourselves and kind of shift the gaze towards you're working in these health or housing facilities, like what is it? What are our like collective reflections, I think, just around what and there's lots I would say too available just around what people have said and they've written and they've shared with us in the past about what they need to feel safe and to get good quality care. How do we move the needle on that? And I wanted to call out there's Equip Healthcare. They have a website that is really awesome, and it just they have things like equity walkthroughs and stuff, and you can do it with organizations and checklists to kind of like go through a space. And as Lexi talked about place and space, how that really shapes access to care, and just really to reflect and to give some prompts for discussion with colleagues around how safe and comfortable and welcoming services are. So that's just the website is down here on the bottom. And then as we're kind of discussing this, I think sometimes it's like we can default to things like next of kin or who's your family or things like that. And what we're asking, and what we prompt ourselves and our colleagues as well to do is to just critically reflect on even the language that we're using around caregiving or who provides care or who is in your circle of support, trying to keep it really broad. And the latest evidence is really around not so much asking about the relationship that is important, but more so like what kinds of roles people are filling. So it can be helpful to say things like, who helps you to get to appointments? Who helps you to get food? How are you accessing this service? And not exactly these words, but just this idea that when we kind of focus more on what the needs are and how people fill those needs as opposed to assuming or defining a relationship, we might be able to then get at this kind of more of a constellation of support. So say it's a worker that helps them get to appointments, but maybe their relationship with their neighbor, maybe they buy food together. And this is like really important part of how they get access to food. So you can start to kind of disrupt that it's one person or a couple people providing all the care, and rather that there might be multiple people in the picture that can be drawn on for support, that can be offered support. Um, and then this kind of brings us to kind of earlier adapted advanced care planning. So really kind of thinking about from these conversations of who is helping in the lives of people, then how do we better document that in our system? So we've worked quite a bit across the country with shelters and housing and stuff, and there are different groups that have modified their intake forms, say for housing, to start to capture some of these things so that they are documented at where the person lives, like who is the person to be called if someone's winds up in hospital. There's definitely projects happening across the country around better optimization of charts and Connect Care, different EMRs to really try to better identify caregivers, quote unquote, or the somebodies in the system that might be called on to support, but then again, who may be offered support too. As mentioned, the caregivers are often people that um, also are facing social and structural inequity in these contexts. So sometimes they are also people who are sick, have disabilities, who need other supports. And as the comment, in the chat around, people not feeling necessarily like welcome or safe in facilities, it's like, what would actually support a caregiver or somebody to come in and be with a person in a facility? Maybe it is offering them a snack alongside the patient. Maybe it is helping them with a taxi voucher to enable them to be able to provide care or sit with the person that is meaningful to them. What is it that the caregiver could use too? This is again just something to think about. And as discussed, this and in the discussion, Sarah, you brought that up too, just like really seeing and valuing the important role of workers. workers won't always be the people that can make kind of medical decisions, but they're definitely often like case managers, housing workers, people that are are trusted by the client or the person who's experiencing homelessness. They're often people that, know a lot about the situation, may be able to like help translate medical directives, orders, like in the community, may be able to support the person to get their medications or get them to hospital, whatever it is. There's so many resources that are available outside of acute and hospital settings that we can be drawing on, but also at the same time supporting and valuing. I don't think we want to just offload work to workers, but really just acknowledging their important role in the circle of care. And some of the things we've been doing over the last few years too, has been really working alongside workers to understand like what are their perspectives on death, dying, what have their experiences been around supporting people in community with serious illness. And we have a resource guide. The link is here, but maybe we could just throw it in the chat as well. And in the fall, we're going to be releasing a curriculum for inner city workers that is just really around trying to strengthen community-based approaches to palliative care in housing and harm reduction, homelessness and harm reduction settings. Um, as you can see in the table of contents, it's really around kind of recognizing when people are seriously ill, talking, like prompting the conversations, planning for the future, getting more support. And then we have a discussion guide on grief and resistance. And this is really not about training non-medical workers to do palliative care, but it's really recognizing this role, as Lexy talked about, that's often like between a worker and a family member, maybe a de facto family or a caregiver. And within those roles, how do we better equip workers that are doing this work every day and are seeing patterns of decline, who are seeing their clients go in and out of hospital without getting the access to care, but more importantly, like supporting like better care for clients and then better conditions for workers. So that's what this curriculum is all about. It's again not about teaching workers, but very much about drawing on the strengths and the experiences of workers to be able to talk about what it really is like to be in these environments and provide this kind of care. Um, as mentioned around the family complexity, like we used to have a lot of like legal support clinics for in homeless settings, and it's very like few and far between. So even kind of getting that support for people to get forms, wills done, like all that kind of thing. And then family support complexity, working through, maybe I want this person to make these kinds of decisions, but not others. We definitely need some more support and capacity around supporting caregivers and supporting, patients to have their wishes not only documented, but like the follow through with what they're saying they want. And then I think the grief support is another huge area, recognizing that the grief that people are experiencing is not just sort of one-time grief, but very cumulative, very disenfranchised, providing care and support and love to those who have, are very much devalued and discarded in society. And we've seen some really cool models pop up around grief and loss support um, across the country. And one of the ones that we just put on this slide is this group called SOLOS in Edmonton, and they do lots of work with workers and people experiencing homelessness and really around cultivating these non-institutional relationships and going to the settings where people are to provide, collective grief support. And there's lots of good examples of that in BC too. So yeah, so we're kind of at the end. And again, this is scratches the surface. It's high level. It's really trying to just talk about kind of some of the things that we've seen in our work over the years. But we wanted to just, yeah, open up the floor again and just ask if there's one kind of practical thing or like just some piece of insight that maybe you want to take with you today doesn't need to be something that we said, but maybe something you were thinking about or something from your own life or work you wanted to share with others. So that's what we're gonna kind of end on today. And I'll just take myself off screen so I can see you. And I haven't heard of Last Aid Facilitator. Katrina, you could share with us if you want to.
Sure. I haven't. Can you hear me? Yeah. I haven't actually started the training yet. So I'll have to keep that in winter. But it was something that just popped up in my email a couple of weeks ago. It's an internationally used program, originally designed in Germany and has been used in a number of other countries, and there is some literature about it. Basically providing 1 hour education sessions for anybody who wants to know about end of life care, death, dying, and grief. It's been so the program is trademarked, and it was originally running in Ontario, I believe, for a couple of years. And they recruit facilitators to run these education sessions. They're 4 1 hour education sessions. I don't know, but I'm assuming they're free since we're volunteers that are running. And they're now rolling it out in BC through the CHPCA. And I just happened to get an email about this last week and looked into it. And essentially, it's an education program for both the people who are going through approach to end of life and for their caregivers. And also, they include workers in the list of people who might be interested. And I saw this and signed up. They were looking for people with clinical experience and people with lived experience. And I wrote to them and said, I think this would be a really useful thing to run on the downtown east side. And they came back to me and said, we're so glad you've joined us. And I don't know an awful lot about it yet, but I'm signed up for so there's facilitator training, which is quite short, actually. It's half a day in November. There is one a little bit sooner, but I can't make that one. And then the idea is that you have to provide these education sessions, at least 2 a year. They don't seem to have done many in BC yet. It listed on some documentation I was reading, they've only had 3 sessions in BC, don't know where. But I'm really hoping that I can incorporate a lot of what you've told me about into this system and see if we can get something rolled out for, in particular, I think about the support workers, the care workers, the bodies, the street support, the all kinds of groups on the downtown east side. And I was thinking particularly about, I mean, you will know the ICART, the Indigenous Crisis Response Team, who are mostly around mental health, but do end up often dealing with people who have serious illnesses and phone us and say help. And yes, we want to, but also some of those sort of teams, their staff don't always know everything that might be helpful to them for accessing end of life support for their clients. And so, yeah, it's watch this space. But Last Aid through the CHPCA, and it seems to be just rolling out now in BC. Thought I would try and find out more.
Yeah, that's awesome. And it looks like Stephanie put the link into the chat. So
Oh yeah,
awesome.
yeah.
Thanks, Stephanie.
And they are actively looking for more facilitators because I think they've not managed to get many sessions rolled out. So
yeah,
anybody who's interested, please look.
Well, and it's a huge need for kind of that education. The reason we kind of start working on ours, and I know Joshua's on the call too, Joshua Black, they did a grief and bereavement education program for, for context of homelessness too, but there's a huge need for adapted, education for these contexts, because a lot of times it's like, a lot of the mainstream ways of talking about palliative care aren't very applicable. Like, and, people are like, oh, like, would you be surprised if this person died within 6 months or a year or whatever? And then it was like, well, no, everyone's at risk of death, as you will know this, but I'm just explaining this for the broader context is like or like infections or wounds that normally would be seen as treatable, but when people are living in contexts of homelessness and that exposure then to the elements and to toxic drugs and all these things, it's like we know that those are shortening people's lives. They're making people sicker, and people are in and out of hospital, brain injury, all these things, right? And so like I think like even like a big prompt for even us working on the education we worked on was just like people were like, yeah, this is a great idea, but like it doesn't apply in our like palliative care doesn't apply to us. Like it's not like people aren't getting to old age, and so shifting that kind of framing of the value of palliative care in these contexts, not only for getting people better quality care when they're living, but also for that support of the circle of care around them. And what we've heard, by from the facilitators and people who have been testing our curriculum out, they're like, it's amazing to be able to sit with this group of workers and, really like talk about the humanity of what it's like to be in these positions where you feel like you're just so heavy weighted by the structural inequity and there's nothing to do. But, it gives us something to do. It gives us like a bit of hope. There's something we can work on here. We can bring in other providers when we frame it in this way.
Mhm.
Like all of a sudden, people who are seen as just addicted are now seen as living with a serious illness that needs attention or something, like that kind of framing and that kind of valuing that starts to be put on people when we just change the way that we maybe sometimes talk about what's going on. Yeah, so I think that, yeah, it's just a big need, I think, to really bring these different concepts into palliative care.
And I love that idea of community capacity building
Mhm.
and really looking at the things that people are already doing and building upon that. And then also, I think like oftentimes palliative care can feel very specialized. So taking that away a little bit and just, yeah, reaffirming that people really actually are doing lots of things in the community. But yeah, again, that community capacity building is huge and really dispersing sort of the roles amongst people and empowering people to yeah, I don't know with that education stuff. So that's really, really cool. Maybe we can connect actually after and see how that course went. And uh,
Yeah. Yeah, I'd love to hear what your thoughts on it, just with your experience too.
mhm.
Yeah.
Um, one thing that it's also prompted in my mind is the situation I've come across a couple of times where when a patient is diagnosed with a recognizable end of life disease, like, oh, they've got cancer or kidney failure or whatever, I've seen on a couple of occasions that their place of residence have just said, okay, we can't have them here anymore.
Yeah.
And there's a huge need for helping those care workers recognize that you can have them there and that there is support that can be brought in.
Yeah.
Admittedly, some of these buildings are not the safest place in the world, but we'll do what we can. And there are, you know, just a blanket throw them out is not the answer at all. And we have to try and help people understand that things can be done and this can work. And yeah, maybe we'll have to move them, but don't chuck them out.
Yeah.
That's just not acceptable.
Absolutely. Yeah.
Yeah, yeah.
Other kind of final thoughts, key takeaways, anything anyone wants to share? We have a bit more time left. Go ahead, Joshua.
Look at that, Dr. Mollison. Hey, it's good to see you. My question, and I'm kind of curious, been curious about this for a while, but what are some of the end of life wishes that are kind of unique to this population? I know one of the things that the Community Death Care Project down in the downtown east side did was they wanted photos. People wanted photos of themselves, looking good and proper. So when they do kind of die, that they have something to give to people and to have in the memorial. And so I wasn't sure what else maybe Lexi and you sort of saw or heard about on maybe some unique things that we just wouldn't think about because we're housed and it's just like we take it for granted. Same thing like memorials, like the thing that you talked about and how important that is, the work that we've been doing. And but so about end of life wishes, like some of the things that you've kind of heard that were maybe surprising or kind of like, oh yeah, like that makes sense, like and never really thought about.
That's a really great question, Joshua. And to be honest, I actually don't think there are a lot of like super unique needs. I would say it's the fact that people don't even feel like they had the choice to make those decisions, and talk about the things that they want. So we do a lot of advanced care planning in the community. And when we talk to people, yeah, like I wouldn't say I've heard anything that's like super like something where I'm like, oh, that's not possible or wouldn't be possible or this is really difficult. It's really mostly people are like, I didn't realize that I had power to make that decision. And so I think it's really more about empowering people and giving them the resources and opportunity to make sure that whoever's involved in their care is there. The people that they don't want involved are not there. Yeah, I don't know, Ash, do you have any unique things or stuff to add to that? But
I mean, I would only say, yeah, I don't think there's anything like wildly unique. I would say like belongings, like people's belongings tend to have more meaning and significance
Mhm.
because oftentimes like when you don't have like say a house to pass on or money to pass on, then like the thing that you've been carrying with you through multiple cities or through multiple housing sites or wherever you've lived and you've actually hung on to that can have a little bit more meaning. So I would just say, yeah, that and then yeah, I would totally agree with Lexi that that was the biggest surprise. A lot of times we were like, oh, you can actually like write something down and people will like follow it. Like that was like a big like shocker to people just after, not necessarily having like experiences of being heard and seen in systems and then like, oh, actually people are asking me what I want for the first time, which feels very profound. Yeah.
That's interesting about the stuff. I know of talking to someone at May's place, and she was saying how they had belongings and they wanted to go to someone, but they couldn't find that person to give
Mm,
belongings to because of someone on the street, and they didn't know when the right time to get rid of the stuff because it was, they don't have the storage for it. And so I was like, those are kind of like some unique things that I've heard along the way,
mhm,
like finding the right person to give the belonging to, especially if they die in an institution like a hospice where maybe the person doesn't feel welcome to come in, especially on the street. How do you then find that person to give them the stuff that they want? Or their
yeah. Yeah. Grace, go ahead.
Thanks. I'm a member of Mom Stop the Harm, and a friend of mine in the group, her son was dying last winter um, of heart failure after being on the street for many years. And she wasn't allowed to take him home with her because of her landlord. And they were going to discharge him from the hospital, even though he was, in really rough shape and only had, they thought, weeks to live. It turned out to be days. And it was really difficult, but they ended up keeping him in the hospital. And I just see, like, it seems to me there's a huge need for some kind of non-hospital clinic for where people who are really ill could be. Um, do you, and I would really like to try to help create a groundswell of demand for this to happen. Do you, what do you think? Is there any chance of that happening?
Okay, this is super interesting. So we're actually in another study right now around dying at home for folks that are structurally vulnerable. And we're seeing this a lot right now where housing facilities are saying that people are beyond their level of care. And so something, unfortunately, pretty much like they have to fall or something, they get sent to hospital. And then the hospital says, like, we're not a housing site, they can't be here. But so there's this tension between the housing sites and the hospital. So I'm just saying we're seeing that a lot right now, and it's really difficult, and no one is assuming responsibility or knows how to navigate it, because people are getting discharged back to the streets when they're like very, very, very ill. But we're doing a case study right now, actually, through this study on a place called George's House in Edmonton. And it's a 5-bed hospice in a residential neighborhood. And they have 24-hour nursing support, social workers, physicians, family and friends can visit. Like there are a couple restrictions and stuff, but yeah, you can use substances on the patio. And it is kind of like this beacon of hope of how things can be and like how community can take care of each other. And I think we do have to get back to that place where we see that as like a collective responsibility. So I would say that's one of the places that does exist right now. And we're doing a case study on it, hoping to one day replicate that and look at the funding structures and the yeah, that just at the staffing support and all of those things and trying to recreate that, um, and hopefully do it. I'm not really sure. It's really hard too when you involve the health authority because there's lots of policies you have to abide by. So they are grant funded and then also funded through some other religious organizations. So they have a lot of freedom in the way they can take care of people. So to answer your question, I do think we can do it.
Thank you. Although I'm thinking not only of the dying, but of people on the street that are very sick. Like I met 2 young women that said they had pneumonia and they were released from the hospital onto the winter streets in the rain where there's no shelter from the rain, you know.
Yeah, I think our discharge planning can be improved quite a lot.
There seems to be a real push to get people out of the hospital, and there's no, it doesn't seem like it makes any difference, or even that there's stigma against them because they're homeless, like that they don't, well, you made your choice kind of attitude or something. I don't know what it is, but I know that there's very sick people on the streets. I'm in Duncan, and I'm sure it's probably even worse in Victoria because you're a bigger city, but I think more than 5 beds are needed. And I also know there's quite a lot of people living in their vehicles that we're not even as aware of. That, like I met an older person with COPD that was hospitalized because of it and then discharged to live in her vehicle while there's wildfire smoke in the air, stuff like that.
Yeah, I think when we started this research 10 years ago, like when I just think about, the numbers of, now seniors and people that have existing disabilities because PWD and pension rates aren't keeping up with the cost of living, and how many people are moving now from, independent housing to living with family and friends to, that falling through and living in cars. And, we're just there, we're just at the tip, we're at the tip of the iceberg of, and when we talk about all of this stuff, we always try to bring it back to like, this is everyone's issue. This is like, we all know someone who's struggling if we're not struggling ourselves. And I think, we're just like, now is the time more than ever to be like connecting the struggles that we're all experiencing and trying to get better care for everybody. Housing, social support, stepping up for our community, meeting our neighbors, asking each other if we're struggling, what can we do to help, all these kinds of things. Because I don't know, I just think we're still at the kind of the tip of the iceberg to the problems we're going to see in the future. So yeah, and so I think we're pretty well out of time. I'm going to put up our final slide, which just has a little bit of contact information if anyone wants to get in touch. I really appreciate everyone coming today, and yeah, it's really great to have such a interested audience and also insightful and experiential uh, audience as well. So thank you so much for your attention today. Um, and here's our final slide. You can.
Thanks so much, Lexi and
Yeah.
Ashley. What an awesome presentation. I know, like, I'm sure a lot of you will comment, like, we feel like we kind of just scratched the surface, but I love that you guys always kind of bring it back to the strength-based approach and that doing the good work and moving that needle and not kind of getting stuck in the deficit because we can sit there for so long, right? And just kind of feel discouraged. So one of the things that I take away, and you were talking just a moment ago, Ashley, about the community building and the kind of using this compassionate community model. And one of my kind of takeaways and learning was just seeing how within this population, not necessarily being stuck in kind of caregivers having one role in this very kind of one directional kind of caregiving, and that we've been able to see through the research and just hearing people's stories and the lived experience of it is this biodirectional giving back and forth. And I think like what a beautiful thing we can learn from that. We can bring our bias and assumptions that there's so much that this population might need, but we have so much I think that we can learn from, and there's so much beauty in that. So that's my personal takeaway, and just thank you again, both of you, and thank you everyone for coming and sharing stories and your experiences. And yeah, we hope to continue on this conversation. We have a related topic tomorrow. We will have Amber presenting on addressing structural barriers to cancer treatment for people experiencing homelessness. I'm going to pop that registration link in the chat. If you're interested, even if you can't attend, feel free to register and to get the recording link. And we will send out an email within about a week following this session with today's recording link, as well as some of the resource links mentioned. And we hope to see you again at another session. Thank you all so much.
Thank you, Stephanie.
Thanks, Esther, for popping that in the chat.